Our first speaker is Rachel Sarafraz. Rachel is the Director of Innovation at Sheba Beyond. She leads the development and implementation of remote care and hospital-at-home technologies at Israel's first virtual hospital, part of Sheba Medical Center, with a career of spanning the intersection of healthcare, technology, and public policy, including key roles at the Ministries of Health and Science. She holds master's degree in both public policy and public health. Rachel is also a board member of Caregiver Israel, where she advocates for family caregivers and health equity. Her talk will be about why do we actually need remote care, what is hospital at home, and how AI-enabled healthcare is a powerful tool for advancing women's health. Rachel, the floor is yours.
Thank you. Okay, let's get you'll tell me if it's working, if the sharing is working. Is it the correct screen? You're muted, Michal, but I'll take it as an approval that I'm.
Yeah. It's
Okay. Okay, great. So hi, everyone. Nice to meet you. And thank you so much to Michal and Ronel for the opportunity to speak with you today and to be part of this conference and part of the great work that Noga Fund is doing. So my name is Rachel Sarafraz, and as Michal said, I'm the Director of Innovation at Sheba Beyond. And today I want to talk to you about women's health as it relates to remote care. So I moved slide, and I hope it moves with you guys as well. So if you're not familiar with Sheba Beyond, I'll just say a couple words. Sheba Beyond is Israel's first virtual hospital. We are part of Sheba Medical Center. We are what's considered the fifth hospital within Sheba Medical Center. And we were established about 7 years ago in order to provide care beyond the walls of the hospital. And so we work in both fully remote and also hybrid models. We provide hospital at home care or home admissions for a number of specialties, including internal medicine, post-operative, psychiatric, high-risk pregnancy, and so on. We also operate a number of hybrid specialty clinics, and we'll discuss that a bit more later in the presentation. And we also provide the platform for teleconsultations in Sheba's outpatient clinics. Sheba is one of the leading organizations in Israel in terms of offering outpatient consultations that are remote. So I actually want to start from the very end. So this is my spoiler to everyone here. And I want to tell you what my thesis is and what I want to argue today in my presentation. What I want to say is this: women's health is not just about diseases that are exclusive to women or about how diseases manifest specifically in women, although those are very important topics. Women's health also needs to include a conversation about healthcare delivery and how we build healthcare models. And the reason why is because women are patients, women are caregivers, and women are healthcare workers, and we're going to dive into that in a minute. So the way that we deliver healthcare services matters to women, and remote care holds the solutions and the answers to a lot of the issues that we're dealing with. So let's talk about women as patients. We know that in developed countries, men tend to die younger. So women have a longer life expectancy, but they tend to have a greater disease burden. And they tend to have diseases that are not terminal, for example, arthritis and depression. And these are diseases that obviously have an impact on the quality of their life and also likely mean that they're interacting more with the healthcare system than possibly men. We know from various studies that women are, in Israel, by the way, that women are more likely to consider seeking out medical attention than women. They might also actually, act on that and actually receive more care. I'll say that I did look for data that compares the consumption of healthcare services between women and men, and I didn't find anything that was really definitive. And I think I can imagine why no one wants to ask that research question, but there actually is a lot of value to answering that question. Women are also more likely to be caregivers than men. So when we talk about caregivers, we're talking about unpaid informal care. Usually it's someone who's for a family member, maybe a friend. And we're talking about caring for somebody who needs help doing everyday activities. So someone who's either ill or someone who's disabled. And you can see in the top figure on the right side that across OECD countries, most caregivers are women, and that includes Israel. And you can see in the graph on the lower hand side, on the lower side of the right side of the slide, that women in Israel, and that's already a statistic from Israel, that women also generally put in more hours than men a week into caregiving. And I could talk about this, for a full hour, and I obviously can't, but you can imagine what that means for the quality of life of those caregivers, for their ability to work, their ability to take care of their own health. Women are also a large part of the healthcare force around the world and also specifically in Israel. These are statistics from the Israeli Ministry of Health. And you can see that with the exception of physicians, women make up the majority of most healthcare populations or healthcare worker populations in our healthcare system. So I think it's possible to say that women are the healthcare system's largest workforce. They are most likely its most frequent users and much of its unpaid care infrastructure. And of course, here we're talking about caregivers. But healthcare delivery, the way that we design our healthcare services and the way that we offer them to our patients are not designed around women. I would argue that they're not always designed around people at all, and definitely not around families. And what do I mean by that? Well, we could break that down into a lot of different directions. And what I want to speak to you about is how today care is still primarily offered in Israel and around the world in clinic, as in person, and synchronous. So, what is synchronous care? Synchronous care means that in order to receive care from my physician or whoever the healthcare provider is, the healthcare professional, I need to be at the same time, I need to be available as the healthcare professional. So that already limits the realm of opportunities of where and when we could meet. And it makes care less convenient. I can say, as I'm the mother of small children, I'm frequently taking my children for example, for vaccines. And those appointments are only available at specific hours of the day. And so that usually means that I need to miss a full morning at work or half a day, or I need to leave work at noon in order to take my children to those appointments. So it's inconvenient care. So what are the costs of inconvenient care? Well, first of all, it means that we're spending a lot of time on the road. It means that we're spending time looking for parking, and there are expenses also associated with that. It means that we're sitting long time, a long part of our day, we might be sitting in waiting rooms. We might be missing from work. There are disruptions to the family routine, missed appointments, delayed care, and all that ultimately can lead to burnout, stress, and mental load. We need to remember that women aren't only attending their own appointments. Women are attending appointments for their children, for their spouses, and for their aging parents, and for anyone else that they might be caregiving for. So an inefficient interaction in the healthcare system will have ripple effects for women and for families. So what are some of the solutions that I think that remote care, or how do I think that remote care can help us? First of all, remote care makes treatment more accessible. So here are two examples of services that we offer at Sheba Beyond. We have a service that offers telerehabilitation, including occupational therapy, speech language, and cardiac rehabilitation. And these programs are remote. So we see patients coming from around the country. In order to receive remote care, it means that very often these patients, for example, might have neurological disorders, and they would normally need a caregiver to bring them to the hospital to receive care. These things can be conducted from the home, so that becomes more accessible. We also have a completely virtual psychology clinic that provides full protocols of treatment for patients with trauma or with anxiety. And it's completely provided virtually. And we see from our statistics that we provide a lot of care to patients, or provide a great number of care to patients in the periphery of Israel because it's much more accessible. Remote care also keeps families together. So here are a couple examples of services that do that. We have a high-risk pregnancy hospital at home program that was set up by Professor Avi Tzur and Esti Geller. So with women who have high-risk pregnancies and need to be hospitalized, what usually will happen is that they will be hospitalized in the hospital. They might be there for a couple of weeks, and they're essentially detached from their families. And if they already have children, they're detached from their children. And that disrupts the entire family routine and life. And of course, if those women normally would be working and they're not able to go to work, that also disrupts their professional lives. This program allows women to be hospitalized at home. They receive an ultrasound at home, they receive a fetal monitor, and it allows them to keep working if they choose to, and also to still be part of their family life. Another program is the Chava Center program for reproductive psychiatry hospital at home. So normally women who would need to be hospitalized after, for let's say for postpartum depression, would normally need to be to part from their babies, from their newborns, and be hospitalized in the hospital without them. And this program allows them to be hospitalized at home. Actually, I'll say within parentheses that Dr. Vered Bar actually set up, I think, one of the first dyadic wards in Sheba, and now women actually can be hospitalized within Sheba with their babies. And the final example I want to bring you is an interesting example that has to do with healthcare workers. So I showed you the statistics before of what percentage of therapists, of occupational therapists and cognitive therapists and speech and language therapists are women, and it's 90+%. And so every time a war breaks out in Israel, healthcare, childcare frameworks are canceled, school is canceled, daycare is canceled, and usually the parents will have to stay home with the children, and that's very often the mother will stay home with the children. And that mother might be a therapist who needs to provide care to her patients, and all of her treatments will then be canceled, and patients won't be able to receive their care. So what Sharon Harel, the head of our telerehabilitation program, does every time there's a war is she trains inpatient therapy, the therapists who work within the hospital to provide telerehabilitation. And that way, those therapists can provide care from their own homes to patients wherever the patients are. And that allows a continuum of care. And finally, remote care saves time. So we've evolved in the way that we look at remote care and what we understand about remote care. We used to look at it as telemedicine, as video conferencing, video consultation between a patient and a physician, and that's kind of where it started and where it ended. And that's great for accessibility. It's not great for availability, and it doesn't save time because you still need, 20 minutes of the patient and 20 minutes of the physician at the same time. And right now we understand that remote care is evolving. It's evolving into a future of asynchronous care. What does that mean? It's evolving to models where we are now able to give care and AI is definitely accelerating this, without the patient and the healthcare professional needing to be available at the same time. And at Sheba Beyond, we are piloting right now models that have to do with asynchronous intake, asynchronous monitoring, and also treatment. I'm going to give you one example. So we all know that very frequently patients will wait 4, 6 months, sometimes a year, for an appointment with a specialist. And then they will arrive finally at their appointment, and the physician will spend a good amount of the consultation going through their paperwork and writing and doing, things that don't actually require them to be present at the same time. And then very often what will happen is that the physician will say to the patient, well, you don't have the blood work that I need, or you don't have the ultrasound that I need. And so actually you have to go do those tests and then get back in line and wait to come back here in order to get a diagnosis or a treatment plan. And so this leads to a lot of inefficiencies in the system, and it exacerbates an existing problem that we have in Israel, which is the lack of specialists that we have across the country. And so what we're doing in this program is we have set up an AI agent that we call him Uri, because right now he's working in the urology department, and he contacts patients about a month before their appointment, and he will collect from them all of their, medical history and what their complaint is, and he'll compile all of that information in a summary for the physician, and he'll also review all of the patient's test results, and he'll identify if there's tests that are missing, and he'll say to the patient, you know what, you should really go back to your family doctor and ask them for some blood test referrals, because if you come with blood tests, this appointment will be more efficient. And so the idea here is to bring patients to their consultations more ready, more prepared, and to make the whole event more efficient. So this is my final slide. And I hope that that I've managed to make the point and to convince you. And I want to leave you with this. If you are a healthcare provider or you're a technology developer, if you are, in your capacity, your professional capacity, you are making decisions about how to design healthcare services or how to provide them, I would suggest that you ask questions like, does the way that we're going to offer this service or technology fit into patients' real lives? What does it look like? How does it impact families? How does it impact the professional lives of the patient who needs to come or their caregiver? And if you're a patient or a caregiver, I would say, remember that you are also a consumer, you are also a client, you are a customer. And you can say to your HMO or whoever's coordinating your care, can I receive this treatment remotely? Or which hospital can you send me to where they'll offer this to me in a way that fits into my life? And even if the answer is, well, we don't have anything right now for that, when enough of those demands are made, that can impact the way that the healthcare providers understand what their patients want. So thank you so much. And I'm happy to be in touch with anyone who would like to continue the conversation. And thanks again to Michal and Renel for the opportunity.